So today I've been asked to come along and speak to you about some brief interventions for smoking cessation. I understand that there's going to be a change in some of the ways that smoking is dealt with in your HHS and in your hospital. So I'm hoping to provide some ideas today about some of the ways that might be useful in terms of dealing with some of the reactions to that change in policy as regards smoking materials, as well as to help motivate someone to make maybe a more longer lasting change in their life when they leave hospital as well. So I work in the alcohol and drug service in Brisbane at Biala, and I manage what's called the Alcohol and Drug Information Service. It's a 24/7 information and counselling line for anyone who has concern about their own or someone else's drug or alcohol use. Also a line that you can call if you require any information about alcohol and drug services as well for someone that you're working with. That number that you can call for that 24/7 is 1800 177 833, and happy for you to pass that on to anyone who might want to utilise that information. Okay, so I'll be going through a quick background and the present situation that I understand is happening for you as regards to smoking, maybe some of the challenges that you're facing, as well as some of the positive situations about the areas that you might be working in, because I understand that most of you watching this are probably going to be coming from a mental health audience. It's fine if you're not, but I will be targeting towards the mental health audience for this presentation today. We'll talk about some of the interventions that might be useful in a brief sense, so when you don't have a lot of time, and some of the ways that that brief intervention can actually be quite effective, possibly even more effective than a longer term intervention, especially in this area of smoking cessation for people who are finding themselves in a hospital or mental health setting. We'll talk about some of the barriers that might exist and ways that you might be able to work through those barriers and assist in coordinating change even in an environment that can be difficult to work within. And we'll talk about some of the resources available for you and for patients who might want to look into this more and use some of the new technologies that exist to assist in making a longer term change to their smoking behaviour. Alright, so the present situation and a bit of a background. So I think some of the difficulties in the setting that you're working with are things like there might be a lot of ambivalence, especially amongst clients, but also amongst some of the staff that you might be working with. So in clients, I'm understanding that someone has come to hospital or mental health, and they're having to do that usually not at a time that they might have otherwise chosen, and very unlikely to be coming to hospital or mental health thinking, while I come here, I really want to make a change to my smoking while I'm here. It's actually not the reason that they are coming to your facility today. They're coming for another purpose entirely, and when they get there, or hopefully before they get there, they are aware that they're not going to be able to smoke while actually an inpatient. And that may be a surprise, or at the very least a source of some a range of emotions that we'll talk about a little bit later that we might need to work through. So that ambivalence for clients is something that we're going to need to focus on and to talk about how to manage. Also among staff, and this is something that comes up very regularly, that there's a range of staff who may feel like an intervention for smoking is something that they're not wanting to be involved in. And that might come from an understanding that that staff member is a smoker themselves and feels like that makes it difficult to intervene when it comes to smoking behaviour for someone that they're working with. My belief is that there's no reason why, if you're presently a smoker, that there would be any issue assisting someone to make a change to their smoking. I think that potentially it becomes an issue if they see you smoking, especially in a place that is supposed to be a non-smoking area for them. That might be a problem. But the fact that you might smoke outside of the work environment, I don't think is an issue for you actually saying that this person actually needs to consider making a change as well. In fact, in some ways you probably have a greater understanding of the ambivalence and the issues that they're working through, because I imagine you're working through some of the similar issues yourself. And we'll talk a bit about an approach to take with staff that may actually take some of that into consideration and help that staff member to potentially work through the difficulties of helping a client with their smoking behaviour a little bit later. Difficulties adding to existing workloads is also a huge area of ambivalence and difficulties with this. You're already doing a lot in your work day. The addition of yet another task I know is stressful and a difficult one to manage. The thing with the smoking pathway is it is designed to be as quick as it possibly can be while still being effective. And we're going to talk about in this presentation how to keep it as brief as possible, and like I mentioned before, how sometimes a brief intervention can actually be more effective than a longer term intervention, and that you're in a unique position to maybe carry that out. Leave handling and searches are going to be, they're already in a lot of places a difficult thing to manage. Potentially this may involve more of that. I have heard some opinions though that in a complete environment where people are not able to smoke even when on leave, just around the hospital, etc., that maybe that will actually simplify the search requirements, because we're not actually handing over tobacco to a person for them to leave, go and have some cigarettes, and then come back and require that researching process to happen. So this may actually simplify things, but I understand it's also an issue that has come up. The pathway completion, as I've talked about before, in terms of difficulties adding to workload, the need to complete a pathway is certainly an addition that is probably not anyone's looking forward to doing, but it is an important part of the process because it actually follows the brief intervention framework. I think there's a bunch of unique challenges in a mental health setting as well. I think a lot of the emotions that kind of come with the what hopefully, as I said, isn't a surprise that they're coming into a non-smoking environment, but the idea of those emotions being raised may also have complications in terms of the mental health setting, and a range of other things that actually happen within that setting as well. I'm not saying there aren't specific complications in the hospital setting as well, but like I said, this presentation is largely targeted towards a mental health audience. Some of the strengths that I think we can work on, some of the real positives that come from the area that you may work in. If you are in a mental health environment, some of the very skills that you use on a day-to-day basis, the skills that you've honed over many, many years, are potentially very useful in this very setting of helping someone to make a change. So your key skill is going to be, one of the key skills anyway, is going to be assessing the stability of a person in terms of their mental status and where they're actually at today. That's crucial to actually designing an intervention, working out when to intervene and at what level to intervene. Because if someone's not in a stable place, as we'll talk about a little bit later, it may not be the right time to get in and do even a brief intervention. We may be doing something far less intense at that sort of point, waiting for the person to stabilise a bit before we're introducing maybe more of the advanced concepts there. I think mental health as an inpatient, and also in the hospital, but mental health as an inpatient provides a unique opportunity to intervene. We'll talk about why that is a little bit later as well, but it comes back to the idea of a brief intervention being best when it's in an environment that can be repetitive, brief and positive. There is an opportunity within the mental health setting to continue the intervention in the community as well. And I think that is a really important one. That means that all of the hard work you do in an inpatient setting may not be lost when the person returns home, because they may well be followed up by a community team who can carry on that intervention if there's a good understanding of what actually can be done and should be done in that setting. In a lot of HHSs, particularly Metro North, I'm aware of, there's a lot of work already been done in terms of smoking cessation. Maybe some of the hardest work has already been done. Maybe many of those barriers have already been overcome in terms of letting someone know they're not going to be able to smoke in this environment. And this is just an addition to that existing work. And so we might be able to build upon some of your existing knowledge already. We have a number of dual diagnosis coordinator positions across the Metro North HHS, and I believe in other HHSs as well, who are well skilled and very knowledgeable in terms of how to make this change more likely to be successful. And specific training can be provided, I believe, by many of those dual diagnosis coordinators on how to approach this. We also have here in the Metro North Mental Health Alcohol and Drug Service, and in other alcohol and other drug services across the state, staff who do this on a day-to-day basis. This is their day-to-day job, and it's certainly my understanding in this HHS that this alcohol and drug service is ready and willing to assist with training and ongoing support in terms of how to actually make a change in this environment with smoking, as well as any other alcohol and drug problems that you might see in your environment. And as I mentioned, if you are seeking that assistance, one of the best numbers to call is that 1-800 number for the Alcohol and Drug Information Service, 1-800-177-833, 24/7. You can call us and we'll be happy to assist you as well as any clients or patients that you're working with. Okay, so before we intervene, before we actually get in and do anything, we really need to think about where this person is at. We need to understand how ambivalent they are, how stable they are, how rare they are for this intervention to take place. And that's, like I said, your unique skills in a mental health setting will assist you within that, because you'll be able to have an idea of how stable this person is, how ready they might be for this conversation to take place, and how far to go with that based on that determination. I've already mentioned it's unlikely to be a key goal for the patient that they are going to change their smoking behaviour while they're an inpatient with you. It's very unlikely that's why they've come to hospital. So we need to handle that sensitively and with a lot of understanding. We'll find that understanding and building of a rapport with that person is going to help you a lot to manage this situation. We've got a couple of slides on that. Our goal, especially while the person is sort of new in their treatment and potentially less stable, our goal may only to be offering support with understanding. We may not be trying to do much of an intervention other than just saying, how can we support you? Talked about the matching stability to and openness of the patient and looking into that, and that sort of where they are on their journey. Is this an acute presentation versus someone who's about to actually go home? And the distinction between those two things I'm sure you're very aware of, and how that might change someone's approach and openness to an intervention for smoking cessation is obviously going to be quite clear to you. Okay. So I want to talk about how we might change this conversation that we're going to have with someone depending on their presentation. I've got 3 pictures to demonstrate what I imagine is possibly some of the common presentations and maybe some of the common reactions you get in an acute presentation when you let someone know that smoking cessation is going to be part of the deal of coming into hospital today. The first one is this kind of very stressed, anxious response. And I'm imagining that a lot of people, when told about the fact that in hospital you're not going to be able to smoke for the entirety of your stay, are going to feel a little anxious about that if they weren't already aware, or maybe even if they are. They might be really worried about how that's going to go. And so that might give you an opportunity to intervene based on that. For example, what are the sort of things that are causing you to feel worried at this point? Where are you seeing this is going to get difficult? What do you think will be some of the ways we can offer some support to you at that time, and make that part of your intervention plan for the person? Oh, look, you know, the first 24 hours are going to be the most difficult part for me. Most people who smoke have tried to quit at some time before and will have an idea of when it gets difficult and how it's going to get difficult. And that can be a lot of this anxiety. Okay, so what are we going to do for that first 24 hours for you to provide some extra support and manage that anxiety? May go a long way to reducing some of that anxiety and getting some greater engagement with the smoking cessation pathway. Very angry reaction. And this comes up a lot in terms of staff worries and anxieties about any changes to smoking policies in hospitals and mental health settings, is the angry, aggressive response. Now, my advice to you at this kind of point is it's possible that at this stage, when you see this reaction, because we've just let this person know about the fact that they're not going to be able to smoke in hospital, now may not be the time for an in-depth 5 A's approach to smoking cessation for this person. They're not very likely to be ready for that. We may need to actually, at this point, merely give the person a very immediate option of understand that you're angry, understand that you feel that this is unfair, perhaps, whatever it is that they're saying at this point. We can offer you support in the form of gum or a patch. Which one do you want, effectively? Just give that person an immediate option, and that's about all we would want to do at that point, and to retreat back from that conversation reasonably quickly, because we're not going to get very far until that person is able to calm down. In terms of aggressive and anger management, once again, you're very skilled in how to manage that, so I know that I don't need to train you in that. When it comes to the smoking cessation, I'd say very brief, an offer of this or that, and then leave that at that point. For this guy, his reaction might be, another challenge, another thing on my plate that I'm going to have to deal with. It was bad enough that I was already feeling pretty sad and depressed, but now I'm going to have to also make a change to my smoking behaviour, and I'm feeling quite down about that. And I feel like this is someone that we can really do a lot of good work with. This may be actually a good time to have a conversation about what some of the challenges are, where the barriers are going to come from, and how we can help and provide assistance. This person may be very open to a discussion about support that you can offer them at this time. Once again, these are just 3 pictures that I've just picked to demonstrate some of the emotional reactions. You're the experts in terms of this stuff and who you see in the acute presentation phase, and you're the experts in knowing the right time to actually have the conversation for that person. But just some ideas about thinking about matching it to where the person's at, how stable they are, and how open they may be to this conversation is important. Why do we do a brief intervention though? Why am I saying this can actually be quite an effective way to approach things? Well, research tells us. So although these are not staggering figures here, we are aware that a brief intervention of less than 3 minutes can make a difference. It doesn't make a difference for everyone. 1 in every 33 conversations made a difference in a primary health setting. However, it still means that a less than 3 minute conversation had effectiveness. And that's 1 in 33 people who actually led to someone quitting smoking. So for a very brief conversation to lead to someone quitting smoking is a really good outcome. Even if it doesn't happen every time, it's still worth doing. We have seen in mental health settings similar figures that brief intervention can be highly effective. The difficult part is it should be carried on for a little longer. So we've actually seen some research that would say it needs to be carried on for possibly up to a year in the community to see the longer term gains maintained. And that's the important thing about smoking, is some people can make that immediate change, but seeing it last, see someone continue to quit smoking, is what we actually want to see in terms of a good outcome. And this is what I was saying before about in a mental health setting, we need to be able to see this continue into the community to see these kind of results actually follow through. Okay, so I talked about that unique environment in a mental health setting being particularly good for a brief intervention, and that's because the message needs to be brief, repetitive, and positive. And so in my mind, I think of what I call grumpy man, the guy who's quite angry when he's told about the need to make a change to his smoking behaviour. Maybe if we actually offered him a gum or a patch and he reluctantly accepted that, perhaps a couple of days down the track when he may be more calm, a very brief, how is that going? How are you actually finding the patch? And if he responds in anything positive, even if it's tough but I'm getting there, a very brief and positive message about that's fantastic, really glad to hear it, can be great. I mean, this can be someone who's actually really struggling with this and you've taken an interest enough to just ask how that's going. The opportunity to do that quite regularly while someone's an inpatient seems to be pretty clear to me, and that could actually be the thing that makes the difference to someone, just knowing there's someone who takes an interest. In the community, that might become their case manager or anyone else who's working with them, who just asks when they have contact with them how they're going in terms of making that change to their smoking behaviour. Is that being maintained? What are the kind of barriers that are getting in the way, and what support can we offer to you? It doesn't have to be a long conversation, but just that very brief check-in in a positive way can be very helpful. Like I said before, adding more to your workload is not what we're trying to do here. 5 A's, and I've got a slide on the 5 A's and how that can actually go through. And I'm sure you're probably already aware of the 5 A's in the pathway. It can take a little while to go through all of those. While you're assessing someone in an acute setting, you might say it's going to be very difficult to do all 5. My approach to this is the first A sufficient in that acute presentation? And I'll tell you why I think that. Because the first A is, do you smoke? And if the person says no, well, you're actually done in terms of your pathway. Complete, done, move on. If they say yes, it means that you can have a very brief conversation about what sort of support they're going to need while they're in hospital, and perhaps we'll leave the other A's for a little bit later in their journey through the inpatient system. I think asking someone, do you smoke, yes or no, is not a huge addition to assessment, although, like I say, the addition of anything is not what we want to do. It's an important question that I think asking that can be done. Highlighting just one motivator can be a very important and brief thing that can be introduced at this point as well. So if someone says that yes, they do smoke and they're going to find it difficult, but they offer you anything at all in terms of something that has been a cause of ambivalence for them, something they're concerned about, something they'd like to see change, just mentioning that back to them. So let's say, for example, I'm having a conversation with someone. Do you smoke? Yes. Okay. Do you know that while you're here, you're not going to be able to smoke? Yes, and I'm going to find that really, really difficult. Okay. What are some of the things that we can do to support you? Patches, gum, that kind of stuff. Great. What are some of the things that might be good for you in terms of making this change? What might be some of the things that you could see maybe different for you in your world if smoking wasn't a part of it? Now, any answer to that question is going to be good. So this person might say, well, maybe I wouldn't cough as much, or maybe I'd be able to walk up that flight of stairs without getting puffed. And just repeating that back to them and saying, oh, that's good. So one of the things you might be looking forward to in making this change is that you might actually be able to improve on your fitness. Yes, that'd be great. Or I might save some money. Great, that'd be fantastic, wouldn't it, to be able to save a bit more money, and then move on. Very brief, but highly effective in highlighting that motivator for the person. Establishing rapport is something that I've mentioned before is going to be crucial to having this conversation. So having a conversation about what they like about smoking can be a really simple way to disarm some of the defensiveness that you see about this conversation. Just tell me what you enjoy about smoking. It just gives someone a chance to actually say some of the things they don't often feel that people are asking them about smoking. Everyone's usually focused on the negative side. No one ever asked me what I like about it. So starting with that question, what do you like about it, can be a really good way to get someone a little bit more on side. And then that makes the discussion about what are the things that aren't so great about it easier to have. Okay, so I'm not going to spend a lot of time on this slide, but I did want to present it. This talks about the 5 A's of intervention. These are the A's that are on the smoking pathway, and you can see there's a fair amount of detail in terms of what's involved there, but that first question can take a minute. Do you smoke, and how much do you smoke if you do? Going down the advise, assess, into assistance, and then arranging, that might be later down the track for the person if there's not sufficient time in that assessment to go through that. On the right side of this slide, though, are an important range of ideas in terms of actually having an intervention for the person that's likely to be successful. So these are the issues of what is going to motivate this person. And this is personal, a very individual assessment of what are the things that are both helping the person to make a change but also getting in the way. Having a look at these things, it's allowed sort of a minute for most of them, 3 minutes for the roadblocks, because the roadblocks are the key area that we want to be able to work with, especially while the person's in an inpatient setting. But not a long discussion is happening here. We're briefly checking in on some of these things and offering some support and advice about that. So it's an interesting slide. I recommend to digest that and have a think about how that might apply for you, and that all of this doesn't have to take a long time to do, but can be highly effective if you get the time to do, if not all of them, at least some. Rapport. So you're not going to be able to have that conversation unless the person feels that there's a level of rapport and trust that they can at least know that you're trying to help at this point and offer support. I wanted to present some of the conversations that might occur here and some of the ways that using a different approach to that conversation could be highly effective in building up more rapport and having a positive outcome. So for example, someone says, "This is going to be impossible, I always smoke." A reaction I think you're going to hear. Some of the options could be, and I've got sort of a versus response here, the way that may actually lead to an argument versus a way that's going to lead to something more positive. So if the response is, well, you just can't smoke here, I think you're going to get into an argument about all the reasons why this person can't make this change. I'll talk about why that's important in a second. If you say, what do you think will be hard about not smoking on the ward? Well, now we're back to actually looking into the roadblocks. We're now doing an intervention just by actually asking that question, and it's a response to the same statement in a similar way, but now we're intervening instead of having an argument with the person. What about, "I'm sure you'll manage," versus, "I'm hearing this is going to be difficult for you. How can we help support you with this while you're here?" So in that statement, in the second statement, there's understanding, but also support. What sort of support can we offer to you? This is going to be difficult, so how can I help? Here's a patch, it'll help, versus would you like to know some of the ways we have to help you with this? So we're introducing choice at that point. I'm not deciding for you what your intervention is going to be. You're an active participant in deciding what you want. You want a gum, a patch, or nothing. You might just want to do this cold turkey. How do you want to approach this? You have a range of options. What is your choice in this setting? Looking into managing resistance though, and this is a similar sort of idea, but it's the idea that the person is now potentially leading you into much more of an argument. A lot of these statements are designed to be the bite point, where if you're someone who feels strongly about smoking cessation, this could be very tempting to get into an argument on. But an argument is very unlikely to end up in being a positive change for the person, and we'll talk about why in a second. But just to think about this, turning a statement into a question can be a little trick. Smoking is the only pleasurable thing I have left in my life. Now, it's very tempting if someone said that to me, to say, surely there's other things that are pleasurable. Let's explore all those other things that might be pleasurable for you, and I can think of 5 already that you've already told me about that should be pleasurable for you. Instead, a question would be a far better approach there that isn't going to end up in an argument. Oh, okay, so what are some of the things you like about it? Going back to that question I said that can be very disarming, let's have a conversation about the things that you find pleasurable. And by having a discussion about that, it then also leads into, oh, so what are some of the things that aren't so great about it? and we've kind of given you the time to talk about what you like about it, it's sort of fitting that we're also going to have a conversation about some of the things you might not like about it. And it disarms that very quickly. A simple reflection can be far more effective than an argument. I can't stop, it relaxes me. I just can't. Once again, very tempting to bite and talk about the ways that this person, I believe you can stop, I believe it is possible, there's other ways that you can relax, etc., etc. But instead, we can turn it around to part of your assessment, part of your A's, 5 A's approach. So one of the things you enjoy about smoking is relaxation. What else do you like about it? So we've actually turned that into a thank you very much for that piece of information. Is there anything else that you can tell me about that you enjoy, instead of that opportunity for an argument? An amplified reflection is something to use with someone you've got a bit more rapport with. This might be a few days down the track. We've had a few of those initial conversations. Now we're sitting down with the person and having more of a discussion, and I feel a bit safer being a little bit what can be seen as sarcasm, but can actually push someone into another level of motivation. My grandmother smoked every day of her life, and she lived until she was 93. I wish I had $1 for every time I have heard this from someone. And I can tell you, I've gotten into the argument before. It doesn't work. It doesn't help at that sort of point. A conversation like this, what you could have is, oh, okay, so you don't think cigarettes are bad for you. Now, it's sarcastic, and what you're actually wanting the person to do at that point is to say, well, no, I wasn't saying that. And then you can say, oh, okay, so what are some of the things you've noticed might be not so great about smoking, and to lead that into that conversation and twist that statement around, if you like, into a different direction. And this is the idea of the person doing judo here, is we're actually using the person's resistance kind of to roll with it and to go in that direction that they're going, and kind of use their force to have them head in that direction. So very quickly, when it comes to motivation and how to develop motivation, I've talked a bit about why some things are more effective than others in terms of that conversation. It comes back to a very key statement in motivational interviewing, which is what the person is motivated by is what they hear themselves saying to you, not what you say to them. This is a difficult one for people like myself who've done a lot of training in this area. I want to feel like the information I'm providing is going to be the useful part of that intervention, and I have to sit back and understand that actually no, it's what that person is saying that is going to be far more motivating. So if we're having an argument with someone about I can't stop, it relaxes me. Oh yeah, no, I think you can. There's a whole bunch of things that could relax you. The person is naturally going to argue with you and say, no, you don't understand how hard it is. It's very hard for me to make this change. I've tried before and I've failed 1,000,000 times. Every time I try and do it, I get really anxious. This person is going to be thinking about these statements they're making, not your reaction to those statements. And so they're going to go away motivated by their negative view of the likelihood of them making this change. If the conversation becomes one of what are some of the things that aren't so good about it, what are some of the things that you've noticed less good about smoking, and they start talking about how expensive it is and how unfit they feel when they climb up a set of stairs, well, now they're motivated by that discussion that they're having in their head about all the things they're aware of that aren't so great about it. And that's really the key to finding a motivation for someone. What are their statements that they make that are important to them about making that change? Identifying that and pressing on that, highlighting that as much as you can, coming back to that. So when you see the person on the ward the next day, just reiterating those reasons that they gave you that were important to them to make this change can be highly motivating for the person. And set up what we call cognitive dissonance. This is the idea that where this person is today is not where they want to be. Smoking is stopping them from achieving the things they want to achieve. These are important goals to them. Smoking is the roadblock to that. I need to move through that roadblock to get past that. Setting up that situation where they feel uncomfortable about smoking, that smoking is something that doesn't fit with their goals and their life, is exactly the situation that we want to try to create in that conversation. I'll say that in a brief sense, but say also that there are whole day courses you can do on motivational interviewing that would go into that and all of these ideas in far greater detail. And if this is of interest to you, I'd recommend that you seek out some of that training. One of the places to obtain that is the place that I find myself today, Insight, on the 4th floor of the Bligh City Community Health Centre. And if you're interested in getting information about that, calling 3837 5655 will get you straight to reception, and you can find out about their training calendar and all of the events that they offer at Insight. Very quickly, when we talk about some of the barriers that you might find in your workplace, this is particularly coming back to that staff ambivalence approach that I started talking about at the very beginning. My sense is that a lot of the things that we understand about motivation and motivational interviewing and the approach to take there could be quite positively applied to staff ambivalence as well. You may tend to find that saying to someone in a staff setting, well, you're just going to have to do this whether you like it or not, is going to set up an argument. And that argument is far less likely to result in that person resolving that ambivalence. Instead of having this kind of conversation, what are the good things about not responding to, not assessing smoking behaviour? And having the person talk about the fact that this is going to add to their workload and they feel like it doesn't really fit with them because maybe they're a smoker too and they've tried a million times before and not got anywhere and la da da. You can get all of that out. What might be some of the less good, or what might be some of the implications if we don't respond to and don't assess this? And actually have the person explore for themselves what might be their own motivators here. That may be more likely to end up in a more positive conversation and at the very least a better rapport in your work environment with you and that person, and maybe at best the person actually saying, well fine, maybe I'll do the first A if nothing else. I could at least ask someone if they smoke. Getting some movement there is what we're going for. The final point there about what motivates staff, what is it for that person that's going to be motivating is that thing to press on. What motivates management and executive is an important question. I always make the point in Metro North, we have the strong support of our executive in this regard for smoking cessation. So that's one of the things we don't have to worry about in this HHS. But in other HHSs, that might be a conversation about, once again, using a motivational approach with your management and your executive if there are some barriers in that place. But obviously do that with caution. Some resources to talk about. The first link talks about a range of brief intervention information for quit line services, and there's some training for health professionals at the quit.org.au learning hub. So you can go onto that website, you can do a bunch of this training live. It's targeted around smoking behaviour and making a change. I think you even get a certificate when you do it all, just to show that you've actually been involved in some PD activity, and that may count towards any PD that you need to do for your year as well. There are some video resources on how to do brief interventions as well that are very good on that website. For people who are actually making the change, there are many free apps out there that are pretty good. If you look at this app, it actually records for the person who's now not smoked for 50 days. It actually calculates the milligrams of tar that are not having to be processed via their lungs, the amount of money they've saved, $618, the 750 cigarettes they haven't smoked, brief intervention about sort of the dangerous chemicals in each cigarette, and this kind of body approach to, I suppose, how your body is now more healthy. It's a very positive, repetitive message, so your phone becomes that message of a well done, keep doing it, every day you're getting better and healthier and richer by doing this, which can be quite effective. My Quit Buddy is this one, but there's a whole bunch of other ones on the app stores that you can look up. So in summary, brief intervention can be effective, best when it's brief, repetitive and positive. We need to think about where the person is when they're coming in and maybe through their journey, and matching the intervention to their stability and their openness. we have a bunch of barriers and resistance we're going to need to work through with both clients and potentially staff as well. Taking a motivational frame to that may be a very positive way to actually work through some of that ambivalence. We need to have very realistic goals in that though, and an understanding that this is difficult and we need to work through it slowly and with patience, using your unique skills. So use what you're best at to sort of approach this issue. There's lots of resources out there. Be careful not to overwhelm a person. If you give them 20 apps that they can download, 15 brochures, quit line numbers, etc., it can sort of be too much. You do want to focus on a couple of key 1, 2, maybe 3 ideas for that person to follow up on. What assistance can we provide? Well, that's the ultimate question. Give us a call and we're happy to talk about what sort of opportunities exist there. It might be training for you, other staff. It may be the fact that we can talk about a place that person can actually obtain some assistance. It may be actually a number that person can call at this point to get some phone back up. And maybe some of these ideas about I'm working with a very difficult person, what do I do in that setting? Give us a call and we're happy to discuss that. That number, one more time, 24/7, 1800 177 833 for the Alcohol and Drug Information Service for you, clients, for someone who's worried about someone with a drug and alcohol problem. And of course the quit line number as well is one that you can give someone if that issue is purely about smoking. But we can refer them to quit line as well if you'd prefer to just give them that one number. Thank you for your time today. I hope this training has been helpful for you and will go on to lead to many people in this HHS and around the state making a change to their smoking behaviour and making things easier for you in your workplaces in this change to some of the smoking policies in your hospitals and HHSs. Thank you.